Hello, this is Neil Hansen. I'm a diagnostic radiologist in Omaha, Nebraska, giving my fourth physics lecture. This one is on basic imaging science and technology. I have several references for this talk. When we originally put together our physics curriculum for our residents, it was based off of the RSNA modules. These modules were designed with what the American Board of Radiology says residents need to know about physics. Many of them are actually not really all that physics heavy. They have to do with a bunch of miscellaneous topics, such as image perception and performance, computer-aided detection, image display processing and reconstruction, PAC systems, computer health information systems. This is obtained, similar information is available in Physics War Machine, who did chapters 3 and 4, other references out there, and some of this will show up on things like the ABR, non-interpretive skills section. It's really kind of a hodgepodge of topics put together. I use Poll Everywhere when I give these topics lectures live. However, if you'd like to kind of play along, in the description of the YouTube video, there is a link to a Poll Everywhere quiz. You can take the quiz along with watching the talk. It'll help keep you engaged and awake if at least every 5 to 10 minutes you have to click something or think about a question to answer it correctly. Here is the link also written out for you. All right, optimism. Unless life hands you water and sugar, your lemonade is going to suck. So again, I put these descriptors out in terms of orienting my physics videos, because this is just an incredibly difficult topic to make interesting, at least I found. So you can polish a turd, but you can't polish a turd, but you can put sprinkles on it. Sorry, are we still friends, please? I have won occasionally teaching awards, so please know I do like to teach. I consider myself a good teacher. However, some of these topics are just very difficult to present in an interesting manner. So why am I giving this lecture? And I've done the classic thing of not clearing out my lectures. I promise in the future I may actually forget this or remember to do this. So here is the talk. Yes, 40% of my residents did think I was lonely. I don't see why that would be. The correct answer is really, a combination of B, I really want everyone to do well on boards, and this stuff could be on it. And C, literally no one else in the department would give any of these talks. So by default, the crap falls to me. That's really what it is. I'm never lonely. Here are 2 pictures of my boys, but sometimes literally just wait in the garage for me to get home and attack me to wrestle once I arrive. I long for the days when I used to be lonely. They were quite nice. All right, outline. So we're going to go over PAC systems, radiology information systems, other informatics basics, computer-aided detection, ergonomics, image display and manipulation, as well as radiology reporting and privacy laws. All right, so what is the radiologist's role in all of this BS, right? If you look at the ACR technical standards, if you think about what's the role of a medical physicist, equipment performance, radiation protection, radiology assistant, patient management, doing selective exams, technologists performing exams using the RIS, PACS, hospital information systems. All of our departments have informatics professionals that really do network management, system functionality, really keeping us functional. The role of the physician in all this is very generic. It's ensuring quality, interpretation, and oversight. Really, there has to be a physician on all of the kind of committees that govern all these other areas to give our input, because we have at least a little finger in all of them, a little piece of the pie in all of them. And so you have to know a little bit about all these things to function within those committees. So what is a PAC system? A picture archiving and communication system. So this is how a typical radiology department flows. A patient is scheduled by scheduling staff. A study is protocoled by a radiologist, picking exactly what to do to image the patient. They arrive and are prepped, oftentimes by scheduling or clerical staff, as well as the technologist. Then the technologist performs and QCs the given study, and then that study is placed onto a PAC system to be read and reported by a radiologist. And then the full circle comes back to clerical staff, which then bill for the study and ensure that we keep the lights on. All right, billing information is usually contained where? So where in all of this is billing information contained? You can pause now if you need more time. The correct answer is billing information is usually within the RIS, or the Radiology Information System. Radiologist work list can be, so the work list we work off of, hopefully most of you live in a modern department and work off of electronic lists and not paper, but it can be either which of the following? Could be either PACS driven or RIS driven. There are benefits to both. I'd say the most common radiology work list is a PACS driven work list done through their PACS system. However, there are radiology departments I know of that for billing purposes and other purposes run their lists of studies to be read off of their radiology information system. What is a radiology information system? It's just the system that supports the entry, use, and storage of the text-based data. So that's scheduling, protocols, billing data. Sometimes radiology reports are housed within the RIS. The PACS system really is for the support and use and storage of images, a virtual file room, so to speak. So there's a lot of information, even though most commonly radiologists use the PACS system, there's a lot of information that's not in there, usually related to building, scheduling, that kind of thing. Now these systems obviously have to interact and talk with each other. The RIS has to be able to communicate with the PACS, which has to be able to function with all the various different modalities that we use within radiology. In addition, there are other systems that are built into these. Many of us have third-party dictation systems like Nuance or PowerScribe, as well as 3D analysis systems like Recon or other imaging software processing subtype of things. Peer review, lots of us have third-party peer review systems that are superimposed within this. So if you look at like this mesh network, all of these different components from all the different modalities need to be able to talk with the RIS in terms of scheduling and billing, the PACS to send their images and store them, as well as other hospital information systems to send our reports out so that clinical referrers can see them. All these different components do similar and different things, having a specialized role within the whole network that is a radiology department. And again, the RAD work list can be RIS-driven or PACS-driven, really differs from where you work. I'd say more common would be probably PACS-driven. You got to go through nomenclature. I feel like physics is kind of like radiology in general, and you really just have to learn what all of these different things mean. Nomenclature, so HL7 or Health Level 7. This was founded in the 1980s to really produce a standardized nomenclature for all hospital information systems so that you could exchange electronic health information, administrative information, clinical, billing, financial, amongst different healthcare entities. As part of this, things came into utilization like CPT codes, or current procedural terminology codes. Those are codes used for billing for different radiology procedures. So literally every study that we do has a CPT code assigned to it for billing purposes. ICD-9 codes, or International Classification of Diseases. These are Medicare and Medicaid coding systems for symptoms and diseases. A lot of the hospital information systems in place were designed for kind of insurance and Medicare reimbursement services, because for every CPT code to get paid for it, it has to be linked to an appropriate ICD-9 code. And one of the things that insurance companies or Medicare can do is if there's not appropriate codes linked up, they can just deny payment for a given service. And then it creates a lot of paperwork and headaches that people have to go in and prove that in fact it was a warranted study. So for the most part, to get paid, we need an HL7 compatible CPT code, which is assigned a relative value unit, or RVU, for our study or procedure and accompanied by a given ICD-9 code. I can't remember if we're up to ICD-9 or 10 or 11 or what now, but it constantly changes. All right, so the RIS. The RIS has much more patient information than the PACS. The PACS has limited patient information, predominantly is utilized for imaging. The RIS is usually needed for billing someone, and the PACS is obviously the main place for image storage. There are hardware components to all of these things. You need servers or just computers. You need archive, especially for PACS system, for old images, because they're such data hogs. You need a display system. You need networking to connect all these together, and remote devices to access these. Within these RIS and PACS systems, there are databases that some people use for research and data mining, work lists, both for schedulers, for technologists, and for radiologists. You have image reviews, business reporting, teleradiology, obviously lots of functions housed within these two components. Examples of what might be in a radiology information system would be a patient name, social security number, addresses, insurance information, email, contact info, all that kind of stuff. In PACS, it's much more limited: name, date of birth, age, what exam was performed, what exam date, accession numbers, that sort of thing. Work list examples. So what all work lists are there? So a technologist has to work on a work list. Oftentimes that work list is done through the RIS for a technologist. Same thing with scheduling. It lists the patient studies that need to be done. It includes, when is someone here? Have they shown up at the reception desk? Are they awaiting imaging? That kind of thing. You may think we never need to work on this. However, I've been a part of several department improvement projects where really the main problems that were causing patient care issues were in the design and implementation of the technologist work list. And I've been involved in a couple department improvement projects where really that was the key to making us provide a better product in terms of patient care. So there you go. There's a radiologist interpretation work list. Of course, we're all familiar with this because it's the bane of our existence, keeping the list clean. You've got to we have all sorts of flags in our work list: stat studies, call reports, call to the clinician, hold and call, people that are being held before we call the clinician, that kind of thing. Some people have ways to flag people that have same-day appointments, all ways to prioritize our work list. There's a lot of artificial intelligence going into work lists where AI can somehow magically find the most important studies and pushes them towards the top because it thinks that they're the ones that need to be emergently read. There's a billing queue in work lists, so those are studies that are done and need to be checked for proper coding prior to sending out bills. So that would be like in the RIS work list for people that work in the billing departments. And then there are also clinician work lists, so every individual clinician gets a work list of studies they've ordered as well as their results when they're available. So while RIS and PACS are within radiology, really we function within an entire healthcare ecosystem, so to speak, which is known as the electronic medical record. All these different things are combined, and they have to function together and talk together, otherwise systems break down. Unfortunately, our institution underwent a healthcare IT malware attack that was designed to destroy the communication between these systems and take a lot of these systems down. It was devastating for a week. Had to revert to paper reports. It made everything inefficient and difficult to do, created a lot of stress on the whole healthcare ecosystem. But really within radiology, we were under particularly high stress just because we are so reliant in everything we do for all these systems to function together that it was really pretty devastating. All right, Epic. A lot of you probably have Epic, or some people have Cerner. That's another really common one of these. What is that? Ours here at UNMC, Epic is the one we use. And it is actually the hospital information system here. So Epic is an electronic medical record. It's has a dominant share in the marketplace, kind of like Cerner, and a lot of radiology practices, just because it's so in common use amongst hospitals and healthcare networks. A lot of radiology systems have adopted Epic as their hospital information system, where billing runs through. It's a good system for linking ICD-9 and CPT codes together. And again, all of these different things have to talk to each other for things to work. If you think about Amazon Prime, Amazon works similarly, where it's a central hub for selling things, but it's got to be able to talk with suppliers and distributors and third-party sellers and individuals all coordinating together. Some examples of systems that we use here at our institution: the peer review system is a peer review system that we use. for radiology reporting. We use a McKesson PACS system. There's a Centricity RIS system. We actually use Epic for a RIS system now, though GE does have a RIS system. There are other systems where you can look up CPT codes as well as ICD-9 codes for various things. Here's the Epic system, and again, like I always, when I bring these up and show examples, these are training patients. These aren't real patients, so I'm not disclosing any PHI or anything. There's a training thing. Ian Northstar is not a real person that is 0 years old. But Epic is the electronic medical record, and we actually run our radiology information systems through it, which is pretty common. All right, server. So a server is a software-based software, possibly a dedicated hardware computer. Sometimes there are virtual servers, virtual clients that facilitate something for other programs and computers. So it's a software or a virtual client or possibly a dedicated hardware computer that serves other entities. What are the server needs? So computer servers are the core of the PACS system. Typical servers include a database server, which supports PACS database applications, interface servers, which support HL7 and DICOM interactions. So DICOM is just the standardized way that images are made that I'll go into in a little bit. Application servers, so there's servers that we have for DynaCAD, which is software for reading breast and prostate MRIs. Archive servers oftentimes are housed off-site, so if there's some sort of a localized fire or disaster, not everyone's images are completely lost forever, which would be a disaster in terms of like comparing cancer follow-ups and that kind of thing. There are external and third-party servers may be used for image processing, or we send some of our cardiac cases away for heart flow analysis on a third-party server. And then there are network servers, which really just serve the network connections and keeping everything together and talking to each other. So all these different servers have different roles within the healthcare ecosystem. A little bit about DICOM, if you've never heard of it. It's in early digital imaging, there was a need to transfer images between institutions, and everyone used a different system for putting together, and a lot of the systems didn't talk to each other. So this digital imaging and communications and medicine system was created. It's just a standardized method of information transfer. I think essentially every imaging place here in the States at least uses DICOM to transfer images, and even most international places, because we'll get sent discs from places as far away as Africa and China, and our system is able to read them because they're DICOM compatible. DICOM uses this grayscale presentation state and grayscale standard display function, where basically it's a standard electronics communication system that maps individual image pixel values to a standard display luminance. And it does this by using these things called LUTs, or lookup tables, which are just source data reconstructed to an image. So every individual pixel gets assigned a specific grayscale luminance, then all that is calibrated and displayed for an adequate resolution. DICOM, basically all modern PACS systems are DICOM compatible. There are multiple DICOM viewers available. Some of them you have to buy and are very expensive, like a McKesson PACS system. Some are free online, available on the web. Others are DICOM viewers which are specific to certain things, like 3D reconstruction of Terarecon, or MIM software, which is specific for nuclear medicine and PET-CT viewing. All sorts of DICOM viewers are out there. Some are free, up to some costing millions of dollars for departments. Most portable CDs come with some sort of preloaded DICOM viewer on them, which automatically launches as an application. Some newer studies are actually being sent on USB ports, but it's still pretty common when you go to a radiology file room and ask for copies of your imaging for them to be sent on a CD. Some examples: Osirix, Clear Canvas, Vitria. Those are all just fancy DICOM viewers for specific purposes. Here's an example of, I think this is a Vitria or maybe a Terarecon station for 3D viewing. There's a DynaCAD setup for prostate MRI, fusion-guided biopsies. There's Terarecon, I believe, again, or possibly Vitria, which is a 3D viewer. And then, Osirix is the Apple viewer. I'm within the Google ecosystem. I got Android phones. So I don't see what all you fancy, creative, love of life people that are into Apple see. But if you are into Apple, Osirix is a pretty good 3D viewer from what I'm told. All right, DICOM, image header. So the image header in DICOM is a header file that has to be involved for all DICOM images. Most PACS systems, you can bring it up. I have a shortcut to bring up the DICOM header, and it includes things like the study date, time, protocol, what contrast was used. A lot of times it'll have very specifics about like what KVP and MA for like a CT was used. So the DICOM header is usually accessible where you can find out a lot of the basic information about image acquisition. What do you use it for? Well, it's got the image identifiers on it. It determines the image display parameters, orientation series. So most PACS displays will have a default hanging protocol, like all my chest x-rays come up the same way. So within the DICOM header, it identifies it as a chest x-ray, so the PACS system knows what and how to bring it up for me. It can be loaded into databases for research. So if you want to look at all, like left knee radiographs or something like that, you can search based off of DICOM headers and databases. And again, like I create a shortcut myself, especially on outside studies that we're reinterpreting. Sometimes I'll bring it up to see what type of contrast was given in other imaging parameters. Here's an example of a DICOM header. It tells you contrast was given, how the scan was acquired, what the slice thickness is, KVP, and other imaging elements that were utilized. DICOM files also contain image data, and the amount of image data depends on a couple values. The number of pixels, which are just little picture elements along each row of the image, the number of pixels along each column, as well as the range of intensity values. And different file types have different storage requirements. So if you look at like a ultrasound image, it might have 8 bits of data within it. It's much more simple than like say a colored image that's used for like Doppler or other things like CT, MRI, X-rays may have more bits. They have more gray levels, and inevitably like mammography is universally kind of the highest thing because it has the most shades of gray within it. So for those kind of lookup tables or gray levels within each pixel, it has the highest range of values. You can go through and calculate how much a storage a given image would be required. The RSNA module takes you through this. I'm not sure how relevant that really is. I'd rather you just have a basic idea of how much memory is required for any given type of study. Which brings us to our next question. Which of the following takes up the most memory in a PACS system on average for a given individual case? Pause now if you need more time, but the correct answer is A, digital mammogram. By far and away, radiographs on a per image basis have a lot more information. They have a lot more grayscale values, a lot more resolution. Their pixels are smaller, and mammography is the extreme example of that. So if you take one image from a CT, MRI, ultrasound, plain radiograph, and mammogram, inevitably that one image for mammography is always going to have the highest amount of data encompassed within it. If you look at image size here, a computed radiograph might have 10 megabytes. Digital radiograph has more, 18. CT really and MRI and ultrasound usually are a lot less in terms of their ability to have different shades of gray within them. And then if you look at a mammogram, I guarantee it's not on here apparently, but it would be the highest of them all. The key of all this, radiology needs a lot of servers, a lot of memory, and it takes a lot of money and a lot of really skilled IT professionals to keep all of this stuff running so that we can read a chest x-ray. All right, moving on to the next topic of this potpourri of random stuff, computer-aided detection. So radiologists, other than me, of course, are imperfect. Human eyes are imperfect, and the visualization of contrast on different modalities at a certain luminance setting may be imperfect just inherently. All of that has led to work on computer-aided detection where we can use computers to try and make us better at our job. Foveal vision. So if you go back to the fovea from human anatomy, within your eye is our best and most detailed vision, but it's the only part of the retina that actually has what we consider 100% visual acuity for humans. It's and if you look, you can look at luminance and contrast, and different levels of contrast at different units of luminance. And if you look at our vision, a lot of people have studied vision, distribution of rods and cones. We all have that blind spot in our eye where the optic disc occurs. A lot of this stuff is just pointing out excuses for why we make errors. So errors are oftentimes inherent just to visualization. Someone lacked proper visualization to hit a blind spot or something like that. But there are also other errors that are beyond our eyes. I can't blame everything on the anatomy and evolution of my eye, all right? Whenever I make a mistake, it's not always just because of my foveal search pattern. It could be lack of experience. It could be poor image quality. That can lead to bad mistakes. Could be distractions. This is probably the most common one, especially for residents on call. You just get distracted within your physical environment, or maybe lack of experience. You don't have a good search pattern. So there's lots of different factors on why we make errors. The goal is to see all of our areas of interest. That's why we have a search pattern, because you can't just look at the center of an image and expect to pick up everything. Most of us look on a chest x-ray at the airway, the bones, the lungs, the heart mediastinum. Basically what you're doing is you're focusing your fovea on the individual parts of an image. Interestingly though, if you stare at an image too long, it actually can lead to poor performance with kind of an increased number of false positives. So there's an ideal amount of time for an expert to look at things. Usually, as you look at the number of cases and how accurate you are, first and second year residents don't perform as well as third and fourth year residents, which are not as good as fellows, which are not as good as the gold standard, which would be a fellowship trained mammographer. But if you look at these bubbles, as you gain experience and look longer, a lot of times your accuracy will dip down in part because you will find more false positives or find things which are just not important. So sometimes there's this, and I observe this in second year residents, I tell them all, where first years can be somewhat accurate, but they just miss a lot of stuff. But if they find something, it's almost certain to be important. And then as people go through and they become more skilled and they see more, there's this mid second year to end of second year process where they find everything and they call way too much, and they're overcallers until about their third and fourth year where they kind of balance out. And then early fellows a lot of times experience the same things, in my opinion, where they find a bunch of stuff that's just not important. It's just they've become so skilled at finding things that they start to see things that they previously didn't even see, and they go through a process of becoming an expert where then they call stuff appropriately. And I find a lot of times if you compare a fellowship trained radiologist to a non-fellowship trained radiologist, it's not that the non-fellowship trained person is missing a bunch of stuff, because oftentimes they don't. It's just I think that a fellowship trained radiologist in their area of expertise oftentimes is better at just calling something as normal and ignoring it versus like a non-fellowship trained person may find it, not know what it means, and equivocate or recommend more tests. I think a lot of times that's where fellowship training comes in to be beneficial. So what are the different error types? Well, we have two basic types. A type 1 error is called a false positive, like telling this male patient that he's pregnant, or a type 2 error, a false negative, like telling this obviously pregnant woman that she's not pregnant. There are visual error types, which are related to an incomplete search pattern or satisfaction of search. Satisfaction of search plagues younger residents a lot. It's where you find a finding and you're so excited that you found it that you don't look for the second finding, which may be just as important or even more important. There are perceptual visual cues, like if you're tired in the middle of the night, you would have found it if you were fresh in the morning, but your perception was just off because of fatigue. There are cognitive error types. This also times I find is a younger resident error that gets made. It's where you saw it and described everything correctly, but you just made the wrong decision. So you saw it, you found an abnormality, and then you just decided, oh, there's a normal variant, when in reality it's pathology. And then there are global impression errors where you see and decide on everything, you know it's abnormal, and you just put it together wrong. So an example of that would be recognizing that dilated, thickened small bowel with a focal transition point are all abnormal, but you called it an ileus when in reality what you just described was a bowel obstruction. That's just global perception type of errors. Satisfaction of search, that's where, you find maybe these calcifications here, but you miss the spiculated mass that's hiding in the corner of the image. Benign breast calcifications, but also a right upper outer quadrant spiculated mass is kind of hiding behind the pectoralis muscle. All right, additional errors. All of these errors have led to a desire for CAD or computer-aided detection. The goals of CAD are to reduce radiologist cognitive and perceptual errors, to reduce inter and intra-observer variability when interpreting a study, and to improve workflows, basically to make us faster at boring, monotonous tasks. The question is, we have boring, monotonous tasks, and robots will be able to replace it, but will they eventually be able to replace us on the interesting tasks? And then will they be able to replace us at kind of all tasks altogether? And will our referring physicians then be coming to consult with this person here, or a cyborg woman, to get their imaging studies read? I always tell our medical students to relax if they have these. I've been a part of radiology a long time. I think we are a very long ways off of artificial intelligence and computers doing our jobs. Honestly, most of the CAD systems we have in use are really not that helpful at all. And certainly I don't find them to make us any faster. So I think we still have many generations of radiologists to train prior to having to worry about this. And at that point, I think really once a radiologist and the complexity of what we do on a day-to-day basis, once that can be kind of replaced, I think almost every physician will be in jeopardy at that point. So we'll all be living on that, what's Mark Zuckerberg or whoever one of those famous IT people advocate as just a standard allowance wage from the government. We'll all be living off of that at that point in time. All right, most CAD systems, including mammography, are prone to which of the following? Pause now if you need more time. The correct answer is false positives. Most CAD systems are really prone to false positives. How a CAD system works is image data is put into the software, then there's an analysis module, which is a processor, and then there's an inference engine, which is a decision maker. So data gets put in, there's computer output out. Image input data goes to an image processor, which then goes to a decision maker and then creates an output. So an image has to be pre-processed. Usually there's some sort of target segmentation because we're trying to find targets in radiology. That is detected, then various features are extracted out of it, and then it goes to target versus non-target classification, i.e. is this a tumor, is it normal, and then it goes to some sort of CAD output. There are two basic uses in CAD. CAD-E is detection, which is like what's used in mammography. It's used to find spiculated masses or suspicious calcifications. I'd say most of the CAD programs in development right now are just detection. Things that use AI, for example, to try and find pulmonary nodules or specific lesions in the brain or liver hypodensities. Really CAD-X, which is the other clinical use for programs, are used for decision and diagnosis. These are being worked on a lot, but they're really not in clinical use yet, and I've never seen one that really works all that well. For example, it might be something that finds a threshold of malignancy, so not just finds a pulmonary nodule, which is somewhat of an easy task for a CAD program, or theoretically would be, versus a much tougher task is saying, hey, in this pulmonary nodule, what characteristics are there that show it's going to be a cancer that's invasive in 10 years. So, this is kind of the gold thing that we'd like to know because, radiologists are really good at finding pulmonary nodules or adrenal nodules. Much more difficult to tell which ones are clinically relevant at this point in time. So really the only commonly used CAD system clinically right now is mammography. It's been FDA approved since 1998 as a second reader. Of note, even though it's been in use for over 20 years, it's not approved as a primary reader of radiographs. It's nearly perfect for finding calcification, and it's pretty good for finding masses. But the main problem is that it's very prone to false positives. So some of these systems have up to one false positive mark per image. So again, that goes back to what's an expert good at. An expert is good at not just finding things, but also knowing when to ignore things. There are still a lot of mammographers out there that are, when really experienced, say that CAD systems are of little use to them, that they almost never add anything to their interpretation. Although there are lots of people out there that have told me anecdotally that CAD systems have helped kind of train their eye to find microcalcifications because it's just so good at finding them that it really is of benefit. So it is in widespread use. Breast MRI has color coding schemes for enhancement patterns. There are also some CAD systems in place for that where it will put red on suspicious enhancement characteristic areas. All right, lung nodules, I mentioned that before, just given their conspicuity relative to the air-filled background lung. Computers are quite good about finding nodules. It's never really been shown, though, is it really beneficial to find more nodules? In some situations, like in patients that are considering undergoing a metastectomy for like metastatic sarcoma, it's very important to find all the nodules. Versus in other cases like incidentally found pulmonary nodules related to most commonly old granulomatous disease, it's extremely unimportant and it may even be deleterious to find more pulmonary nodules to the patient. So these things are still in development and use. There's lots of experiment going on to finding CAD in CT colonography and colon polyps. Again, these systems tend to be very prone to false positive. DynaCAD for prostate, prostate MRI is a little bit more quantitative and has some high contrast, so there's a lot of work looking at can a computer find prostate cancer in high grade, specifically clinically relevant prostate cancer better than a human. Again, I still read an awful lot of prostate MRIs, and I don't think a computer is going to replace me or anyone else for at least several generations. All right, so the next thing we got to get into are all of these things that you learned in undergraduate medical school. You got to revive them in your brain for your ABR test to get through it once again. So the number of true positive responses over the number of patients with disease. What is correct for that? Pause now if you need more time. The correct answer is sensitivity. So it's the number of true positives over the number of patients with disease, sensitivity. Next question is, what is the number of true positive responses over the number of positive responses? That would be the positive predictive value, which basically tells you how well a test works. So if you look at sensitivity, specificity, positive and negative predictive values, you will be expected to know what all of these things are. And they're especially applicable to CAD systems because they're commonly used to determine how good a CAD system is. They're also commonly used in radiology accuracy evaluation research. So if you're reading a study about a new study, let's say there's a new CT scan which just detects brain metastases, and it's a new type of CT scan, and should we be doing this on everyone with lung cancer? So the studies will look at it and they'll pop out sensitivity, specificity, accuracy, positive and negative predictive values. So you can expect at least one or two questions on your ABR core exam that will cover this. So I would have these definitions kind of down pat. Some people like to memorize these, like true positives over patients with disease, sensitivity, true positive responses over positive responses in total, positive predictive value, etc. Some people like to think of these more in terms of like the diagram, the old 4-quadrant diagrams of positives versus negatives in terms of actual value versus predicted value to find the true positives and negatives. Whatever gets you through to know what the definitions for these things are is beneficial. This is a ROC curve, or a receiver operated curve. So which ROC curve is the best? And actually, let's see if I can Sorry for the technological snafu there. So I have A, B, and C. Which one of these ROC curves is the best? So if you were reading a chest x-ray, which one of these ROC curves would you want to be? Would you rather be A, B, or C? Or would you rather just have my curves because everyone knows I've got the best ones? All right, so which one is the best? Obviously, A. So if you look at a receiver operator curve, you want to be towards the top left corner as much as possible. A 1 on this scale or being at the top left corner is basically a perfect test. C is kind of a worthless test, so it's kind of sensitivity versus 1 minus the specificity. That's what a ROC curve is, a receiver operating curve. This is most commonly used in radiology literature to kind of talk about how well someone is doing in interpreting a scan or using a test. It plots reader sensitivity versus 1 minus the specificity, and the area under the curve really determines your diagnostic accuracy. So if you have an area under the curve of 1, which by definition means your curve has made it to the very top left part of the graph, that means you're a perfect test. Those really don't exist in medicine, especially not in radiology. But what's considered good when a new test is coming out, basically most of the diagnostic tests that we use, such as like a CT scan of the chest for pulmonary arterial emboli, or looking at a CT of the abdomen and pelvis for appendicitis, a good diagnostic or typical diagnostic test has an area under the curve of about 0.85. So if you have a test, a new one that comes out, and it's got an area under the curve of about 0.9, that's considered very good. If you have a new test that comes out and the area under the curve is like 0.6, that means it probably doesn't work as good as stuff we're already using. It's probably a bad test. And if the area under the curve is 0.5, if it falls along C or is even worse, it's kind of a random chance worthless test. So unfortunately, on bad days, especially when I'm on a low-carb diet, I'm down here at the random worthless reader. My boss would be up here at the top left. My boss, the perfect reader, and then, everyone else is somewhere in between. All right, so comparing ROC curves. So again, this is a worthless curve. This is a good curve. A really excellent curve would be here. If you're an individual reader along this curve, so let's say you're a person that puts a very strict threshold on things. A strict threshold would be down here to like the bottom left. So that means that you're not going to make very many false positive things. Something is really going to be certain before you call it. Most people want to get to a moderate threshold so that you're only overcalling in certain cases and working up stuff additionally appropriately. And then some people have a very lax threshold, so anything that could possibly be positive, they're calling positive. They're overcallers. Those are the people that are calling too much things, overcalling findings and working them up inappropriately. So we all want to be here on the operator curve, not down here, that means we're missing stuff, and not up here, that means we're overcalling stuff. I put these mental health breaks in, so I'd encourage you now to just pause, maybe go get a snack, stretch it out, watch some funny YouTube videos, and take a break. You can look this one up if you want. I like it. I like videos of people that hurt themselves on accident. If only, videos reflect real life. That's what I usually do. So take a break if you need one here. Moving on to the next topic, we're going to go into image display and manipulation. So image display, most monitors that we use are now digital, and most of them are either an LCD, LED, or OLED. Those are just liquid crystal displays, light-emitted diodes, or organic LEDs. And you don't have to know a lot about the specific of these, just know that they kind of exist. For cross-sectional images, the display is always better resolution than the modality inherently. So for like CT, MRI, ultrasound, the display that we're viewing it on is always better than the actual image itself. That's not true for plain radiographs, especially like computed radiography or digital radiography and mammography. So if you look at DR, CR, and Mammo, you actually need a higher resolution display or monitor than you need for like CT and MRI. So for example, if you're buying a new monitor for like a home setup, you could buy like a 3 megapixel monitor, which would be good enough for CT and MRI, but it might not be good enough to do chest x-rays and mammography according to like ACR standards. You might need a much higher megapixel setup. And inevitably, like a work setup for MRI and CT is cheaper than a plain radiograph setup, which is cheaper than a mammographic pack setup. Mammography setups always have to have the highest inherent resolution and luminance displays, and they're always the most expensive. In addition to the actual monitor itself, the display is important. You have to have proper postular, display quality, workstation functionalities like CAD systems, ambient lightings, noise in the background. Those are all important to be an accurate test. So in terms of ergonomics within a radiology reading room, ambient light is supposed to be around 20 to 40 lux. That's recommended for most imaging. Some people like it even darker than that. It takes around 15 minutes for your eyes to light adapt. So theoretically, you should be waiting a little bit. That's why I come in and check my email first before I read anything, for the residents that wonder why I'm not harder on the list. I swear to God, I'm just letting my eyes adapt. I'm not checking my email to see if I got that new toy on eBay that I've been bidding for. I swear. Dimmer switches with indirect lighting are preferred in reading rooms. Direct light can cause glare and reflections. That's how you know you've arrived as a radiologist, if you're complaining about some weird ambient light that's 15 feet away interfering with your interpretation, if you become a prima donna. I like the RSNA module for reducing visual fatigue. The easiest rule is every 20 minutes, look 20 feet away for 20 seconds. So when you're stressed out on call and your eyes are fairly tired, why don't you try that? Even though displays are orthogonal to the viewer, it's recommended that you maintain a close orthogonal, or even though displays are usually not orthogonal, it's recommended that you try and avoid, or that you get as close as possible to this. So basically, where you're looking, you want your eyes to be going straight out. If you're looking up at a display or down at a display, it's deleterious to like your neck. Unfortunately, like carpal tunnel syndrome, neck problems are problematic, especially in diagnostic radiology where we're sitting all day, or if you have a stand-up desk, I would advise trying to do that. Really, I think it's best, most people recommend to just vary what you're doing. So, stand a little bit, move your display around if you have a mobile desk to be up, down, and otherwise, so that you're moving around and not getting these stress injuries like carpal tunnel from scrolling all the time. There are lots of different devices. Some people have foot scroll wheels, different headsets, all sorts of different things to kind of minimize repetitive stress injuries, especially related to the carpal tunnel. Stand-up work displays, or these work displays like with a treadmill, are becoming more and more common in reading rooms. And by and large, I think, if you can vary how you're positioned during the day, it will be beneficial towards your eventual functioning as a person that has to, stare at a screen for 8 hours a day. All right, now going into image processing, it's mostly about computer magic. Which of the following is a cross-sectional mathematical reconstruction algorithm? Pause now if you need more time. The correct answer is all of them. So filter back projection, Fourier transform, iterative reconstruction, those all describe ways that images are made. So basically it's magic, right? Anything that I don't understand, I just call as magic. So there's some, input of, information that all of these different MR, CT, plain radiograph, mammographic receptors receive, that then undergoes mathematical reconstruction and creates an image that we can see. I'm not going to pretend to know how this happens, but I do know the basics of what occurs. So like filter back projection is probably the oldest type of mathematic reconstruction that's utilized in radiology. It's a mathematical algorithm that takes raw data from image detectors and reconstructs them into a viewable image. For example, a CT scan in 3 dimensions. It uses all these different filters to make a single image view that looks like what was exposed to radiation, right? Goes through all these different iterations to eventually make something that looks like this phantom, which is what was originally viewed. A Fourier transform is the mathematical reconstruction used in MRI, and it's just a mathematical process used to work out the meaning and location of different signals that are obtained by a receiver after RF pulses are introduced into the magnet. So MRI, when you get into that, the basics of that, it's basically the receiver is detecting currents and mathematical field alterations, and those are turned into a picture through a very complex mathematical reconstruction process that I quite honestly just don't understand. Iterative reconstruction uses several different iterations to reconstruct raw data rather than one single step, as in a filter back projection. This is what most modern CT scanners are now using. It takes a longer time and needs more computer power. So if you're working with older CT scanners, they're probably still using filter back projection. The thing about iterative reconstruction that's beneficial is it allows better image formation from less data. It tolerates more noise, so you can get better quality images while using less radiation and exposing the patient to less radiation. So that's why all the newer technologies are using this rather than filter back projection. It's again, you don't really need to know the math, which is pretty complex for it. Just know that you can get a better image quality with lesser radiation using iterative reconstruction. There's multiple names for these things, and every different vendor has a different type of iterative reconstruction that they've derived, and they call it something fast. Like we used a lot of GE scanners, and they'll use, I think they call it Acer or Acer V or MBIR. Some Siemens scanners use, I think they call theirs Sapphire. So there's all sorts of different ones. Philips calls theirs IDOS, just fancy names to describe the way they reconstruct images. Now to go into some random processing techniques that you need to be aware of as a radiologist. One is volumetric imaging. What is it? It's where the raw data is reconstructed into 3 dimensions for display. It allows for luminal views like 3D colonography. It allows for determining anatomic relationship. Is this a toy to play with? Is it a tool to make diagnoses? And somewhere in between, where certainly it makes a lot of great images for patient viewing and understanding things, or image display in a book. I'd say in real life, a lot of volumetric imaging is not highly used by radiologists. I think our clinical colleagues like it a lot better, and it's a lot easier for them to explain things to patients who aren't as familiar with axial and coronal anatomy. MIP, or maximum intensity projection imaging. This is where preferentially objects that are only having voxels. It preferentially selects out objects that are within voxels that only have the highest intensities within them, allowing them to kind of pop out. So only the brightest things get displayed. This is useful for finding lung nodules in the dark background of the lungs. It's useful for anything with IV contrast, which is usually CTAs, PECTs, MRI angiographies. MIPs basically take really bright contrast and accentuate it, making it more easily ascertained by the eye, and they eliminate all the background stuff. MIP, an example of a maximum intensity projection image would be a 3D spinning man image that you see on like a PET CT scan. Only the brightest voxels are shown, which is where the FDG tracer went. There's been lots of studies that show your ability to find pulmonary nodules is better on MIP images than on regular images, so some people include MIP images in their search pattern for pulmonary nodules. Here's a statement. Is this true or false? Radiologists get paid for doing 3D reconstructions. The correct answer is actually true. So we do. You can bill for it. So if you go to the the length of making 3D reconstructions, and you can actually bill for it. Do we do that here? Actually not. We probably should, because my kids, as you know, need to go to college, and the things aren't looking real promising for scholarships, right? You don't get scholarships for playing Fortnite and Roblox, do you? I don't think you do. So I'm in a lot of trouble, so I better start billing for those 3D things. Actually, there are some kind of scrupulous or immoral private practices I've heard of out there that actually make 3D recons for a lot of stuff and bill for it inappropriately. In reality, they're really not that useful for much diagnostic-wise. They're more for like explaining to patients and that kind of stuff. All right, subtractions. So subtractions are a way to digitally alter images. Here's a subtraction MRI which shows a breast cancer. Easier to see it once you've subtracted out the background, fibroglandular tissues, and fat. Here's a digital subtraction angiographic image. Those are used very common in IR procedures because they really allow the vessels to pop out and allow you to do road maps, which help you manipulate catheters and wires as you go up into your desired target. Here's an example of addition and fusion imaging. So a PET CT is where we take a CT scan and a nuclear medicine PET image, fuse them together, and it really highlights abnormalities like this lung cancer that you see here. There are fusion biopsies. So you can do fusion biopsies using MRI scans and hybridized ultrasounds. We do this here at our university for prostate cancer biopsies. Some places will also use a hybridized ultrasound MRI to biopsy liver MRI abnormalities that aren't readily apparent on CT or ultrasound, where you can fuse them together in space and do a targeted biopsy that way. There are also quantifying softwares, so this is used a lot in nuclear medicine, where you quantify the amount of radiation delivered in the heart to see if there are areas of infarct or ischemia, or you can quantify amounts of radiotracer going in the brain to diagnose things like Alzheimer's and FTD, as well as like DAT scans and Parkinson's disease. So there's more and more imaging quantification software out there to help you make diagnostic decisions. All right, the final boring thing to talk about is radiology reporting. You should all be aware of like standardized reports. I'm sure a lot of you will be using them in your departments. There are people that swear by these reports, make their career out of designing and using these reports. And there are some people that really, they make a lifetime out of complaining about these and saying why you shouldn't use them. I happen to think they're pretty useful, although admittedly I don't use them I don't use them for everything. I use them for a lot of things like pancreatic cyst follow-up, pancreatic masses, cholangiocarcinoma, prostate MRI. I don't use them if I'm just routinely reading like a random abdomen and pelvis CT, although I think I probably should and may switch in the future. I think there's a lot of benefits to them. But RadLex is this RSNA-designed language ontology thing that's trying to get us to use more standardized reporting and nomenclature. I think there are a lot of benefits to this, although a lot of logistical challenges. But what you can get out of this is, let's say you don't have a good template for something. Templates for things like chest x-rays are pretty easy because it's a limited search pattern. But if you're doing something like a brachial plexus MRI, where maybe you only look at these a couple times a year, having a well-designed out search pattern and filling it out is very beneficial. And I think for things like musculoskeletal MRI, where you have a checklist of things to look at on every knee, the ACL, the MCL, blah, 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 you're really going to be beneficial to have a good template. And on this RSNA informatics reporting website, you can look up what the experts say your template should be. And I've gone on here when we've designed things like we have a rectal cancer MRI template that we utilize because there's just so much you have to talk about. It's easy to forget any individual one of them. And filling them out in a standardized fashion really prevents you from missing something. Is this the future? I think it is. There's lots of third-party payers and fancy computer systems that are trying to make our reports better. I think really we're going to have a standardized report. We'll be able to more easily incorporate images into that report, which is beneficial to both clinicians and patients. Patients are seeing their reports now through patient portals more and more, so having nomenclature that they can understand and easy or understandable follow-up guidelines, I think will be more and more important. And I think to make these things time beneficial, we'll be leveraging a lot of computer technology, AI, automated macros, and I think our reports will only stand to get better and probably will do so by leaps and bounds going into the future. So I'm excited to be a part of that. So that concludes our talk. These were very boring topics, hodgepodge topics, but they're all fair game for the ABR core exam. You really, as a diagnostic radiologist, should know about them, and at the very least, it will prevent you from looking stupid in front of somebody. So I would put some time into these non-interpretive type of skills, not only to get through your core exam, but to become a functioning radiologist. Thank you for your time, and have a good day.